Okay, good evening, everybody. Welcome to this another session of 47 comprehensive course of echocardiography, online one. Today we have with us none other than Dr. Samir Shrivastava, who is a director of cardiology and chief of non-invasive cardiology at BLK Max Super Speciality Hospital, Saket, New Delhi, to talk upon a very important aortic and pulmonic stenosis, how to evaluate by echocardiography. Dr. Samir was in his Fortis Escort Hospital, New Delhi, before moving to BLK Max Hospital. A very good clinical cardiologist, apart from excellent non-invasive cardiology. And today he looks after the various interventional process which happens in Max BLK Hospital, like mitral clefts, TAVR, LA appendage closure, and many other things which are the state-of-art echo examinations today. With these few words, I hand over a mic to none other than Dr. Samir Shrivastava. Please, Samir, it's all yours. Please start your proceeding.
Hi, good evening to you all. And again, as usual, it's always a pleasure to be a part of this forum because more than anything else, it adds on to my knowledge of echocardiography.
Samir, a simple one thing I forgot to mention, we had more than 6 lakhs viewers in Drop Echo Institute from last 2014 onwards, and more than 8,000 are following every time.
Wow.
That's what Google's data.
Google झूठ नहीं बोलता. Google.
So all like friends, you like who have made this program.
Your efforts
for a big
are all attachment files.
So please share your slides and let's move on.
So this is assessment of echocardiography and aortic valve. I'll walk through and then we can have some discussion. Normally, aortic valve is called as a semilunar valve, and it is ventricular aortic valve. There are 2 ventricular aortic valves. One is aortic and another
I'm sorry, interfering. Samir, can you enlarge the slide, please, for me? Wine bottle downstairs.
Yeah.
That's what Mona told me.
Yes. You can't see it, slides?
We can see the slides, but...
you can't see the wine bottle.
I can't see the wine bottle out here. So just enlarge so that it becomes maximum in size. Okay, fine. Go ahead. Still is quite visible. Go ahead. Go ahead. No, not this way. Not this way. Not this way. Previous setup was fine.
I've gone into the slideshow mode.
Yeah, slideshow mode is a little different. Let's go back to the previous mode, please. That was good. Here the slides are getting cut.
Okay, let me just share because it's a long talk. I want it to be appropriate.
Yeah, perfect, Samir. That's perfect.
Okay, so this is aortic valve stenosis, and we know that there are 3 cusps, 3 crescent shaped, 3 commissures, 3 sinuses, and supported by a fibrous annulus, which is important because it is the annulus which holds and seats the valve. Whether it is natural valve or artificial valve, it is the annulus which seats the valve. Normal aortic valve area is 3 to 4 centimeter squares, and at times you can find that there are certain small nodes which are called as nodes of Arantes. Now this is a long axis view which you go into parasternal long axis in diastole and systole. It opens up, and when you look at the systole and diastole, the way I remember the name of the cusps is, the top one is Raj, lower one is Narayan. This is Raj Narayan, which means The top one is right coronary cusp and the bottom one is non-coronary cusp. You don't see the left coronary cusp in short axis, in parasternal long axis. So you take measurements in diastole for all the LV dimensions in diastole. In systole, you take dimensions for the annulus, you take dimensions for the sinuses, and there is a little bit of a ridge. The moment the sinus is finished, this ridge is called the ST junction, which is the sinotubular junction. It has assumed importance because this is the place from where the aorta actually arises embryologically, and this aorta should be traced in all patients of aortic stenosis because it is the dilatation and effacement of the sinotubular junction, which actually is one of the predictors for aortic aneurysm or dilatation in aortic stenosis. Well, you twist the transducer to 90 degrees and you find that you are in a short axis, and in short axis you see what you see as the number of cusps. Now it is very important that not to comment on number of cusps in diastole. Why? Because many a times, I'll show you in subsequent slides, many a times there is a raphe which doesn't open up, but actually it's a bicuspid aortic valve. So you have to see an opening of this sort, which is a triangular opening where you know that all three cusps are opening and they are pliable, and it shows that it is a tricommissural valve. So bicuspid versus tricommissural valve should always be commented in systole. Always be committed in systole. Now, apical 5-chamber view is the most favored view to look at aortic valve anatomy, and not only that, it is one of the most favored views to look at the gradients, because it is here that you can best align most of the times. There are other views also, we shall talk about it, and I'll show you some examples how to show them. Then there is a suprasternal view, and this view is actually one of the best views to see for gradients in case your jet is more aligned towards the superior side and less towards the posterior or anterior side. And that is the reason why a suprasternal view should be an inclusive view in all the aortic stenosis evaluation, regardless of whether it is mild, moderate, severe, how confident you are that there is no aortic stenosis. If you have to, in fact, suprasternal view should be a part and parcel of any good echocardiographic examination, whether it is aortic valve or no aortic valve. This is a classical M-mode normal aortic valve, and in this aortic valve, if you look at it, the RCC and the NCC, they open up in a box side, and it is important that you have to time it, because there are several times that there will be a premature closure of aortic valve, or there can be a mid-systolic closure of aortic valve. If it is a mid-systolic closure of aortic valve, hunt for hypertrophic obstructive cardiomyopathy. Hunt for hypertrophic obstructive cardiomyopathy. However, these are issues where you have to be careful about what you are dealing with, because this is something which is very important, and at the end of the day, it is the shape of the box which matters so much. This shape of the box should be like a box, and this complete line of closure should be central. Now, this is a very important imaging method to find out whether it's a bicuspid aortic valve or not, because most of the times bicuspid aortic valve is an eccentric closure line. That means it is not right in the center. It is either superiorly or inferiorly, and if it is not central, hunt for a bicuspid aortic valve. This is the first indication that you get that you might be dealing with bicuspid aortic valve. So in children, many a times it is just 2% of children are born with bicuspid aortic valve. In fact, 1.8 to 2.2% children are born with bicuspid aortic valve. And if you, how do you suspect it? Because if you don't suspect it, you'll not be able to do a surveillance. All bicuspid aortic valve patients should be under surveillance, not necessarily for valve. Actually, These days, bicuspid aortic valve is not considered as a disease of valve. It is considered a disease of aorta. So in case you've forgotten or not seen bicuspid aortic valve, then what you are doing is you are forgetting that this kid has to be followed up and has to be under surveillance for aortic valve disease or diseases of aorta, which could be aneurysm or dissection in future. So, well, as an imager, I know that this centricity can be man-made, it can become eccentric or central, but by and large, understand that if you are seeing an eccentric motion line, start hunting for it. And that's the reason why this centricity is important. Now, when you look at the causes for aortic stenosis, bicuspid aortic valve with calcification is the commonest cause in children and young adults. Post 60 years, senile or degenerative calcific aortic stenosis is the commonest. We in our country are still struggling with rheumatic aortic stenosis, but it's easy to differentiate rheumatic aortic stenosis from rest of the aortic stenosis because of two major differences. How do you differentiate rheumatic aortic stenosis from other aortic stenosis? One is that if you are seeing aortic stenosis with mitral valve disease, which is rheumatic, that means mitral stenosis, you're pretty much sure. And number two is that if the commissures are involved, then it is rheumatic. If the commissures are spared, then you are probably dealing with senile or degenerative calcific aortic stenosis. Less common are congenital hyperlipoproteinemias, onchorosis, but onchorosis is actually more of a disease of the ventricle or the muscle rather than a valve. It has a very classical feature, but very aggressive nephro units will be referring patients for you because this is a childhood disease where nephrologists pick it up more often than us, and when they send you for a routine echo for whatever reason, then you pick up onchorosis. Now, combination of short and long axis images are needed to identify number of leaflets, mobility, thickness, calcification, and Doppler is the thing which allows determination of the level of obstruction. One, whether it is subvalvular, valvular, or supravalvular, and not only the level of obstruction, but it also identifies the severity of stenosis. Transesophageal echocardiography may be helpful when image quality is suboptimal. In adults, I propose that for all aortic stenosis patients which are going for any intervention of any sort, transesophageal echo is a must. Now, there are certain calcifications over aortic stenosis. The nodular calcific masses on aortic side of cusp can be seen. Most of the times, if it is non-rheumatic, the commissures are free. This is an important differentiating feature. The free edges of cusps are not involved and stellate-shaped orifice is seen, and this is actually calcific aortic stenosis, which is tricommissure. How you suspect? The first thing which you suspect is on the parietal long axis. All of us do that all the time. This is the first image that we seek in an echocardiography. And whenever there is a parietal long axis view showing echogenic and immobile aortic valve with calcification, start suspecting degeneration slash CKD slash hypercalcemia. Calcemia, those are all things which happen with calcification of aortic valve. Now, the moment you go into parietal long axis, you twist your transducer to 90 degrees, go into the short axis, and then you start identifying calcified aortic valves, immobility of cusp. This may look only slit-like, but the valve orifice is in systole will be stellate. That means it will be opening like a tricommissure or the Mercedes-Benz sign. This is bicuspid aortic valve, just for sake of statistics, not that it matters, but fusion of right and left coronary cusps is more common as against right and non-coronary cusps. And this is with a ratio of about 4:1. 80% of the times it is the right and the left coronary cusp which gets stenosed, not really of any significance. Initially, people thought that if both right and left coronary cusps are getting involved, is it that they are more prone to develop coronary artery disease or left main disease or right coronary artery disease? And when it is only right and non-coronary cusp, then it doesn't matter, because most of the times the sinuses are spared from where the arteries are originating. So it is not the valve which matters. So it is just a matter of statistical jugglery, which didn't turn out to have any clinical significance. Now, this is what I was talking to you. There are two pictures. One is on the left and another is on the right. In the one on the left, in diastole and systole both, clearly there are two cusps seen, both in systole and both in diastole. However, if you look at the picture on the right, in diastole, when the valve is closed, the raphe is sealed. But the moment it is in systole, you find that there is an oval-shaped opening, slit-like opening, and the non and the left coronary cusp are fused. So this is a fused raphe, if you can see that. So I will go back because it's very necessary. I missed on something which is very important. I'll go back onto my slides and try to. Okay, so here is a place where I would want to nomenclature the aortic cusp. Easiest to identify is interatrial septum. So if you look at this interatrial septum, the cusp which is next to this interatrial septum is the non-coronary cusp. The one which is towards the right side, or RVOT, is the right coronary cusp, and the one which is on the left side is the left coronary cusp. Here you can see the left main also arising some bit in both systole and diastole. But that besides, this is how you give name to the cusps. There are three cusps: non-coronary cusp, which is adjacent to the interatrial septum; the right coronary cusp, which is facing the right ventricular outflow tract; and the left coronary cusp, which is facing the left ventricle or the. So coming back to our discussion and furthering our discussion from here. In parallel long axis, you may have an asymmetrical closure line. You can get systolic doming, and doming is very important, and diastolic prolapse of the cusps in case there is an aortic regurgitation. Systolic doming is something which your eyes must catch, because there are several formulae in which you can't put those formula unless you have a stenotic valve. To give you an example, if you have a mitral stenosis, you can't use it for a normal valve. Pressure half time is a formula which all of us are so heavily dependent upon, but we can't use it for a normal person. For me, if you take my pressure half time, you'll record my mitral valve area as maybe 2.5, which qualifies to be a stenotic mitral valve. So how do you know that it is a stenotic valve? So the way you identify stenosis of any valve for that matter is you have to see doming. Unless you see a diastolic doming in mitral and tricuspid, you are not justified to use pressure half time, because that is valid only for stenotic valve. And how do you identify mitral and tricuspid stenosis? By doing by looking at the doming in diastole. Similarly, for ventricular aortic valves, whether it is aortic valve or pulmonary valve, how do you define stenosis? By seeing a systolic doming. So this doming is the curvilinear and not a straightforward flattening which occurs, and this doming is quite sine qua non and diagnostic of a stenosis. Now, in adult stenosis, typically it is, you see calcific changes, you can't identify actually the number of cusps, and many a times it is difficult to label it as a bicuspid or a tricuspid valve. And in case there is any confusion, please get transesophageal action into the mode. Reason being that it is very important to prognosticate. It's not necessary to just treat the valve, but it is important to prognosticate for future. And the prognostication is many a times dependent only on one thing, that whether it was a bicuspid aortic valve or tricuspid aortic valve. And the prognostication is necessary not only for valvular degeneration or survival, but it is important for aortic aneurysms and dissection. Now, this is, you can quantify degree of valve calcification, but again, not necessarily so. And actually, echo has lost the race for quantifying calcification of any valve for that matter. And CT scan has taken over, and this is how you do calcium scoring of aortic valve. One of the criterias for severity of aortic stenosis is how much of calcium is present in the aortic valve. So for women, if it is more than 1500, or for men, if it is more than 2200 calcium score by Augustine Hounsfield's units in CT scan, that qualifies it to be called as a severe aortic stenosis, regardless of what the gradients are. This is one of the criteria which has been discussed recently. Now, calcium is bad or good. We can debate on this till cows come home. But to put the things in right perspective, surgeons don't like calcification, and people who are into intervention, they love this calcification. It should not be nodular, but if there is a valve which is severely stenotic and there is no calcium, the interventionists don't like it, because the anchoring of the valve is dependent upon presence of calcification. If there is no calcification, the chances are that the valve can pop off. Now, why do the surgeons don't like it? Because to make the valve, to seat the valve, they have to dig across calcium. And many a times in doing this process, they can hurt the AV node and they can cause complete heart block. So this is something which has become a matter of great debate and discussion, but all the same. Now, elderly population will have some kind of a thickening of aortic valve. And how do you differentiate this thickening from pathological stenosis? So thickening of calcific valve with preserved mobility is typically aortic sclerosis if the peak Doppler velocity is less than 2.5 meter per second. So 2.5 meter per second is the cutoff. Lesser than this, provided there is a big provision that your left ventricular functions are all normal. If your left ventricular functions are abnormal, then you are in big problem, because then this may also qualify to be a severe aortic stenosis, because when the left ventricle is poor, it can't push out blood with the same velocity as with a normal LV, and poorer LV velocity. This is known as a low flow, low gradient, poor LV phenomena. And in these patients, it is better to do a debutable stress echo and see low dose debutable to see what is happening to the gradients in the aortic valve area. Okay, so here we come for our bread and butter valve of the country. This is rheumatic aortic stenosis. Like I said, here the commercials are fused as against degenerative, where commercials are by and large spared. The orifice is triangular, thickened, and calcification, and it is almost always accompanied by rheumatic mitral valve changes. So at your and my level, if there is any aortic stenosis which does not have a rheumatic mitral valve involvement, it is not rheumatic aortic stenosis. There was a point of time where all valvular heart disease in young, we used to label as rheumatic because that was the norm. But over a period of time, we have understood that unless mitral valve is involved, aortic valve should not be labeled as a rheumatic heart disease. So this is the sum and substance of this slide. This is Patterson short axis view. Again, it's a triangular opening, and this is severe aortic stenosis where the commissures are fused. This is a very interesting picture where if you look at this, the aortic valve is opening fine, but there is a ridge here. There is a membrane here. And this is subvalvular aortic stenosis. So there are three types of aortic stenosis: subvalvular, valvular, and supravalvular, which is the hourglass. So here, if you see, this is the subaortic membrane. This is a thin, discrete membrane. This is nothing but an exaggeration of endocardial fold and fibrous tissue. And this is diffuse tunnel-like in LVOT many a times. It can be an accessory or anomalous mitral valve tissue. But if it is only selectively from the LV side, septum side, then it is best not to be labeling it as an anomalous mitral valve tissue, but to label it as a subaortic membrane. This is an hourglass. This is typical. These arrows show that there is a thick fibrous ring above the aortic valve with less mobility and has easily identified hourglass appearance. And this is supravalvular aortic stenosis. Unfortunately, short of surgery, you don't have a solution for that. Here, there is yet another supravalvular aortic stenosis, which is thin, discrete, and membranous. So as against, this is membranous, this is, and then there is a third type, which is a diffuse narrowing, which is seen in pediatric population. Now, how to assess aortic stenosis? Doppler came out with 4V square, and that has become a bane for most of the echocardiographers. And unfortunately, or fortunately, it was this which was the gold standard for all practical purposes for severity till very recently. So you can measure the peak velocities, you can measure the mean velocities, and you can measure the valve area by continuity equation. You should use continuous wave Doppler because velocities are very high in aortic stenosis. And the moment you start using any other Doppler, say for that matter, pulse wave, the aliasing will occur and you'll get all sorts of erroneous or artifactual readings. So which are the views which you use? Certainly, you should use at least 5 windows to look at the velocities. Apical 5-chamber, suprasternal, right parasternal, subcostal, supraclavicular windows, which are difficult to make because the lung interface is too high. And the one which I have learned from Dr. Rakesh is the right anterior oblique window. So whenever you people are here, we would be very happy to demonstrate that. It's a wonderful window. Not very many people are exposed to that, but I've started using it and I've learned it very proudly from Dr. Rakesh and these. So what you need to do is that you have to take 3 or more beats and are averaged in sinus rhythm. But with atrial fibrillation, you should take at least 5 or 10 beats is what is recommended in the American Society of Echocardiography. So AS jet velocity is defined as the highest velocity signal obtained from any window. Any deviation from parallel intercept angle results in velocity underestimation. The problem is that if it is anything greater than 20 degrees, the cos theta factors starts acting and the underestimation or is a lot, and it can be almost to the tune of 30 millimeters of mercury. So angle correction should not be used. There used to be commercially available machines where in these equipments automatic angle correction was factored in, but it should not be used because it is likely to introduce more error and give unpredictable jet velocities. The velocity scale should be adjusted so that the spectral Doppler signals fills on the vertical axis with a time scale on the x-axis to 100 millimeters per second. This should be the scale at which the frame should move. Ball filters are set at high levels and gain is decreased to optimize identification of the velocity curves. So this velocity curve is of two types. One is smooth curve with dense outer edge and clear maximum velocity should be recorded. And the edges, which are rugged edges, should be avoided. It should be clear cut signals. Now, peak trans velocity is here. If you look at this, there are two types of jets. One is here with a velocity of 400 plus, typically a very severe aortic stenosis, and the bottom is 2.6. Now, very interesting. If you look at the bottom one, fortunately, there is a scale here on the right side. But even if there was no scale, a sharp eye would say that this is not a severe aortic stenosis. Why? Because if you look at the peaking is rather early during the systole, as against this, where the peaking is mid or maybe late. So this is exactly a translation of what you studied in third year MBBS, that aortic stenosis has a pulse which is pulsus parvus et tardus. There is a slow peaking, slow and peaks. So this is slow, means there is a mid to late systolic Doppler peaking. And when it is early, it is early. So if you look at this, this is falling far short of the mid path. So if you look at, if you draw a trace from here to here in the center, the peaking is far earlier, and that's the reason why. So it is a shape of the velocity of the curve which is important, that if it is more curved, more rounded, delayed peaking, then it is severe aortic stenosis. Early peaking, triangular in shape, this means it's a. Another very interesting thing, if you look at this, I would be very happy to hunt for a subvalvular stenosis. Maybe this person has got a gradient and a gradient. This is a gradient in gradient. Both of them are showing it. So it is not artifactual. So if you have a gradient in gradient, start looking for an LVOT obstruction. Start looking at a mid cavity obstruction. Start looking at a elderly population will have a sigmoid septum, and this sigmoid septum can enter into the left ventricular outflow tract and give rise to a gradient of this sort. So if you look at this, this is a gradient and gradient. So develop this habit of picking what is odd here. Now this is a transvalvular flow velocity which is coming right in the late stage. Now I wish we were in a interactive session, but if you look at this, this is late systole, and this late systole is not only late systole, actually there are two peaks. One is an early peak, and then there is a second peak. So this is what typically happens in a hypertrophic obstructive cardiomyopathy, where the initial phase pushes the blood, and then because of the SAM, there is a sudden cessation, and again the second peak is a little high. So this is a dynamic subaortic obstruction, and it is a characteristic late peaking, and this is concave upwards and in late systole. Now, world has moved off, and fortunately across the Atlantic also they have come in some kind of a unison that what should be the label to label aortic valve stenotic. So instead of peak velocities, which have their own relevance, I'm not saying that they have lost their relevance completely, but it is the mean gradients, which is the pressure difference between left ventricle and aorta and systole. The mean gradients are calculated. So you don't have to work too hard to do it. All you have to do is trace it, and all commercially available machines have this inbuilt algorithm to calculate mean gradients, and you can calculate. So cutting across the borders of Atlantic, whether east side in Europe or the west side in America, both now believe that any gradient which is more than 40 millimeters of mean is severe aortic stenosis, and how you calculate that is by Bernoulli's equation. And this is calculated by averaging instantaneous gradients over the whole of ejection period. So this is 4V square will calculate the max, and you take the gradients all across by tracing it, and it will give you an averaging of the instantaneous gradients over the whole period of ejection period, which is mean transvalvular gradients. So this is something which we'll keep discussing till you finish your echocardiography, and we'll keep discussing it ad nauseum, Bernoulli's equation. So I'm not getting too much into it. All of us are aware of this. Now, where are the errors it can occur? Errors can occur because aortic valve, if you just look at the top 2D picture and look at the top 2D picture. Aortic valve and mitral valve are too close. And if the eccentricity of mitral valve is there, then aortic stenosis valve and the mitral valve gradients can overlap, which becomes a major issue. Now, how do you differentiate just purely by timing? Purely by timing, if you look at it, mitral regurgitation is a pan-systolic, holosystolic. So how do you define holosystolic? Put your cursor on the R waves. If there is a gap between the R wave and the Doppler signal, rest assured this is not mitral regurgitation. Because in mitral regurgitation, this is pan-systolic. Right from the word go, the gradients will start surfacing. This is one way of doing it. Second is that with tricks, and you can fool the gradient, and you can separate the gradients, and you can put the Doppler right across. But this is one way of recording man alignment object and ultrasound wave. There are certain more sources of error. You can have underestimation of aortic velocity resulting in even greater estimation of gradients due to squared relationship between velocity and pressure difference. Proximal isovelocity should be ignored. And we know that once you start doing it, you'll start picking it up. There is something known as pressure recovery. Very interesting. This is conversion of potential energy to kinetic energy. So again, we'll come back to our basic physics, which was described by Venturi and Bernoulli. Both of them were scientists of the same era, same conference. They presented the same paper that high pressures lead to low velocities and vice versa, and high velocity leads to low pressure. So this was very interesting, which is more often now seen in prosthetic valves, but you can see it in native valves. It was actually described in native valves first, that the narrowest portion is the place from where there is the highest velocity. And when you put the pressure across in this segment where there is highest velocity, you might record very low pressures. But the moment you go distally, you'll start finding that the pressure recovers. And this is known as a pressure recovery phenomena. Again, with advent of continuous wave, this pressure recovery phenomena is seen more seldom than what is described. But since we are discussing theory also, it's appropriate to discuss this. Now, this is how you calculate the aortic valve area by continuity equation. Whatever comes in has to go out. So if you know your A1, B1, you can calculate A2, B2. So if you have LVOT diameter, you can have the velocities across LVOT diameter. If you have the velocities across the aortic valve, you can calculate the aortic valve area. So A1, B1 is equal to A2, B2. And if you don't know any of the parameters here, we don't know the aortic valve area. So what you have to do is A1, B1 divided by B2 is your area. This is exactly what the issue is, that cross-section across LVOT into velocity time integral instead of velocity. Now it is velocity time integral, which has been replaced divided by the velocity time integral of aortic valve, and you will get the aortic valve area. So these calculations require aortic jet velocity, it requires LVOT diameter, and it requires LVOT velocity. The worst of this is LVOT diameter, because you commit error in measuring the diameter of LVOT and your errors are squared up. So this is, I am very convinced that whenever you have to take alveolar diameter, please zoom up as much as you can, because with a zoomed view, you will commit lesser of errors. Again, if you want to put pulse velocity for LVOT, where should it be put? Not in the PISA. This is the PISA. Don't put your velocities here for LVOT velocity. Avoid this and then put it. So this is going to be the pulse wave samples for continuity equation for aortic stenosis. This is how you take measurements after zooming up the LVOT.